so today I'll be speaking about midfoot arthritis, this is a discussion about the pathophysiology and some of the treatment aims. So to start with the anatomy of the foot. So the foot is made up of the hind, the mid and the forefoot, and the midfoot is really referring to the cuboid, navicular, cuneiform bones and the joint which they make with the metatarsal bones. The Restraint joint is variably described, but in reality actually includes all of the tarso-metatarsal joints across here. So there's 5 Restraint articulations that make up the Restraint joint. The cuneiform metatarsal and also the cubo-metatarsal. The other joint to consider is the naviculo-cuboid joint, or the cubo-navicular joint. So these are important articulations to consider. The midfoot, or the mid and the forefoot, can be divided into columns, and this is based on a paper back in 2003. The medial column comprises the first ray, which is the first metatarsal phalanxes, and the medial cuneiform. The middle column is the second and third metatarsals with corresponding middle and lateral cuneiforms, and the lateral column being the fourth and fifth metatarsals with the cuboid. Also to discuss is the hindfoot to midfoot articulation, which is the Charcot's joint, the transverse tarsal joint, and this comprises the talonavicular and the calcaneo-cuboid joint. This diagram notes the changing angle between the talus and the calcaneum, between inversion and eversion of the foot. The hindfoot to midfoot articulation is important to consider because it varies between toe-off and heel strike, being very rigid during toe-off and flexible during heel strike, and this increases the lever arm of the Achilles complex. I haven't got a diagram of all the ligamentous complexes around the mid and the forefoot. However, it's important to consider the first and second metatarsal mobility, which is very limited. There's a very limited range of motion between the first and second tarso-metatarsal joints, whereas there's a lot more motion between the fourth and fifth tarso-metatarsal joints, up to 20 degrees. The second TMT is the least mobile of all, with about 1 degree of motion based on biomechanical studies. The action of these joints is to provide stability and translate forward propulsion to from the hindfoot to the forefoot, and therefore increase that lever arm of the Achilles complex. Also important to consider the longitudinal arches of the foot. So there's the medial longitudinal arch and the lateral longitudinal arch, and this is supported by the spring ligament or the plantar calcaneo-navicular ligament, and also the plantar aponeurosis. Moving on to the different arthritides of the midfoot. So the most common cause is the post-traumatic arthritis. But other arthritis can occur, so primary osteoarthritis or non-traumatic, inflammatory arthritis, including rheumatoid, but also gout, which can lead to long-term degenerative changes. Also neuropathic conditions such as Charcot's neuropathy, as well as chronic pes planus deformity, whether that be congenital onset or adult onset pes planus. But post-traumatic, as I said, is the most common cause. And a study which was quoted in the JOS article which I was referring to said that up to nearly 40% of fractures or major injuries occur to the foot and ankle in car accidents where modern airbags are deployed. And this is almost on par with hip, thigh and knee injuries. And they also note that, particularly in the multi-trauma setting, often these foot injuries are missed, so it's very important to diagnose these problems early, look for swelling of the foot or pain in the foot in these patients, which may be hard to pick up for pain because they may have other distracting injuries, and certainly at least do some plain imaging if not a CT scan if you're at all suspicious. And so as I mentioned, Charcot's disease is another type of problem which can lead to degenerative arthritis. It's a destructive arthropathy occurring from a multitude of different causes, but the most common we see at the moment is diabetic peripheral neuritis. But in the past, certainly Apley's put down neurosyphilis as the primary cause, based on the book that I was reading from a while ago. And this is really due to a loss of pain position sense, which causes the ligaments of the midfoot to be disrupted, and leading to a collapse of this hindfoot to midfoot articulation, as well as all the multiple joints in the midfoot. This is a diagram some X-rays showing an old Liz Frank injury which was left untreated and led to collapse of the midfoot and later need for fusion. And this one was performed with plate and screw fixation. So I'll show you more of that later on. In terms of the presentation of midfoot arthritis, the most important problem is pain, particularly during weight bearing, and especially during the push-off phase of gait. Most patients complain of pain at the more medial midfoot, particularly at the first and second metatarsal joints, which is tarsometatarsal joints, which is palpated on examination. But other problems can indeed include problems with foot posture, as well as patients complaining their shoes aren't fitting properly. And a study that was mentioned in the JOS article was up to 80% of patients actually have these foot posture or shoe wear problems that they present to the surgeon with. So pain on palpation and also stressing the midfoot on examination. And also to note when the patient is standing and walking, and also standing on tiptoes, the loss of the medial longitudinal arch. Secondary deformities to note also include hallux valgus deformity, hindfoot valgus, and Achilles tendon contraction. I'll mention these later when we discuss the surgical management as important other considerations to address with surgery. Assessment really relies on X-ray, and in particular weight-bearing X-rays, both AP, oblique, and lateral. And if any concerns, or most patients would then get a CT scan to further identify the region of most degeneration, which could be addressed surgically. Here on this X-ray, which is weight-bearing lateral, noting the navicular-cuneiform sagging of or collapse of that joint. Moving on to management. So management is through a ladder or a stepwise approach with non-surgical and surgical options, in particular with analgesia, anti-inflammatories, paracetamol, patients modifying their activities or modifying their footwear to become from less narrow fitting shoes to ones that are a bit more accommodative, and those off-the-shelf type shoes. Corticosteroids can be tried, and I'll speak about those in a moment. But in terms of the other orthotic shoe supports, there are a variety that are available now, from the rocker bottom style shoes, which are transmitting weight from the hindfoot to the forefoot and attempting to bypass the midfoot stress, to other shoe modifications which can be used, or shoe inserts, which include these full-length carbon fibre orthotic shoe inserts. Ankle bracing is not well discussed in the literature, but has been anecdotally found to be of benefit and analgesia. And the main aim of all of these types of treatment is to improve the stability of the midfoot and decrease the load that is forced through the midfoot, trying to bypass it in a way. A study back in 2009 measured the range of motion of the different joints in different planes, so the talocalcaneal, the amount of movement through the first ray and the second ray, and then documented these between normal patients and also patients with midfoot arthritis, and during two different phases, during normal walking, but also stepping up and down steps. And they found that in patients with midfoot arthritis, there was a much greater degree of MTP movement, as well as calcaneal eversion movement. This diagram is actually a summary of all patients who, they didn't have a good table of the patients who had this increased range of the MTP and the calcaneal eversion, but they did discuss that later on. And this is suggesting that patients with a more rigid midfoot, or trying to bypass the articulations of the midfoot, actually have an increased range of motion in these other joints. So So another type of immobilization for non-operative treatment is the Charcot Restraint Orthotic walker, or the crow walker. And this is commonly used for patients where we're trying to stabilize the collapse of in peripheral neuropathy. And it can actually offload the plantar foot by up to 30% in biomechanical studies. These are custom made and obviously quite expensive, usually made of carbon fiber outer and a very well padded inner. And that well padded inner is very important because often these patients have peripheral ulcers as well, which we're trying to take pressure off. So it's important to have them custom fitted. Moving on to surgical management. So the mainstay is arthrodesis, whether that be of the first, second or third tarsometatarsal joints. Also the navicular cuneiform, and it's important to consider whether that's involved. And the fourth and fifth TMT joints, it's controversial as to whether it's worthwhile arthrodesing or fusing those. Interpositional arthroplasty is also a consideration, as well as prosthetic arthroplasty. And as I mentioned before, another preoperative investigation can be selective local injections to identify the region of pain. So firstly with those, a cadaveric study has been done which suggests that actually 20% of these injections may actually leak into other joints, so their value in specifying the region of main pain is less accurate. And this was a study done in Foot and Ankle International Journal, where they studied cadavers, and they had 14 cadavers in total, and they were all injected with the methylene blue injection by an experienced rheumatologist under clinical or palpation of the TMT joints, or by ultrasound guidance, and then they were confirmed with fluoroscopy guidance. And they found that actually just doing it on clinical grounds is very likely to fail. When they opened up and dissected the joint, most of those injections actually failed. So ultrasound guidance is quite important for these intra-articular injections. And so 14 cadavers. I mean, as to whether the embalmment process would have potentially damaged some of those joints or not, it's hard to know. They did note that, that's where they get the statistic from for 20%, that 3 specimens had contrast extravasation or outside of the TMT joint, and so decreases the accuracy of that injection. Moving back to the arthrodesis, considering the column theory, so the first, the medial, middle, or lateral columns. Medial and middle arthrodesis, or first and second and third arthrodesis, can involve screw or plate fixation, and it's the most common area where there is midfoot arthritis. The principles of arthrodesis: preparation of the articular surfaces, reconstructing your mechanical alignment, maintaining with rigid stabilization, and then post-operatively making sure that you protect that until you get bone union, whether you assess that by plain imaging or CT scan. It depends on the different surgeon. And just as an aside, a laminar spreader and small curettes are quite helpful for preparation of the articular surfaces and denuding the articular cartilage. This was a case study mentioned in the JOS article where they used plate and screw fixation. She was a 35-year-old, so relatively young. About a decade earlier had a car accident with life-threatening injuries. Lisfracture fracture was noted but managed non-operatively, and then she went on to develop more medial midfoot arthritis, and then had a first and second rate arthrodesis. Lateral column arthrodesis, as mentioned, the fourth and fifth is less likely to have a good outcome and more controversial about whether you treat it, because it has really a very high rate of complications, in particular stress fractures because of the increased mobility of that area with the tendon complexes. Also non-union of the attempted fusion sites, more prominent metalwear because there's less muscle bulk overlying, more likely to develop chronic pain problems, subjective stiffness, trying to fuse things, but in an attempt to gain union, they aren't used to that extra stiffness, as well as metal failure because of the increased force which is normally transmitted through the fourth and fifth rays. And so here's a patient who had a plate and screw fixation, which then went on to break. So what are the options of lateral column arthrodesis? More about preserving the joint, and so you can use either interpositional tendon arthroplasty or more prosthetic arthroplasty such as ceramics. And there aren't many of these, much literature to support ceramic arthroplasty or interpositional, but in a case study, a series of patients, 6 patients had successful treatment with this interpositional sort of wrap down of peroneus tertius and support with a K-wire. What are the other considerations when doing an arthrodesis to consider? Making sure that there's an adequate skin bridge between the incisions if more than one ray needs to be fused. So that would preserve the vascularity of that skin bridge in between. Whether it's controversial as to whether you augment with autologous or allograft bone, or whether you use bone graft substitute, and certainly the JOS article I read did use a demineralized bone matrix, which is a type of calcium phosphate bone substitute. That was their recommended procedure. Whether you use plates and screws versus just lag screws alone, and there's no good evidence to suggest either is better from all the articles I've read. As I said before, assessing the silver skull test and whether the Achilles tendon is causing some hindfoot problems, and whether you need to do a lengthening procedure for the hindfoot or realign that. So assessing the degree of arthritis, the site of pain, and what the likely post course is going to be for this patient. Other surgical complications apart from those lateral foot problems that I mentioned, metatarsalgia can occur, sort of an unknown pain syndrome, metatarsal stress fractures through the fusion site. That's why it's important to maintain or try to regain mechanical alignment as best as possible. Transmitting arthritis to adjacent joints, and certainly by fusing up the midfoot, there is less movement through the midfoot, therefore the forefoot or the hindfoot needs to potentially compensate for this lack of mobility. And also because in first TMT fusion, patients can develop sesamoid type pain because of the decreased mobility of the sesamoids across the first ray. And the JS article that I read really recommends the quality of the anaesthetic reduction has been identified as the most important predictor of a good outcome in these patients with post-traumatic midfoot arthritis. And a couple more references.